Okay, here we go. Blast off to episode number 5 of At the Table with CASA, presented by California Association for Health Services at Home, with support from Access. Access is a leading global technology platform for healthcare at home, empowering more than 9,000 organizations to deliver care to over 5 million patients worldwide. You can learn more at access.com. That's AXXESS.com. My name is Mark Wilson, and every week on this podcast, we bring you real conversations about important policy issues that CASA is moving on, and hopefully some practical strategies that are shaping home care across California. Before I introduce our very special guest for today's podcast, let's say hello to CASA President and CEO, Sua Vang. Hey, Sua.
Hi, Mark. Great to see you.
It's good to be seen. What a week CASA's had, eh?
Yes, absolutely. It's been very busy.
We just came off of the big, and I heard it was very successful. I was actually in on it. The call with Judy Waltz on Friday about the hospice payment suspensions.
Yes. So we had nearly 200 people register and sign on. We had been getting phone calls and emails from members and even non-members just asking for clarity or more information or asking what CASA is doing about it and have we heard about it. And so we had quickly put together that webinar within 36 hours and just put the link out there. And so it was a great response to get that many people interested. And obviously it's affecting their operations. And so many people are on, and unfortunately, whether they have received the notice or haven't received the notice, their payment is getting suspended. And so it was great to offer that webinar to at least be able to give some clarity on what they should be doing, whether they receive the letter or not, and if their payment has been suspended.
Yeah, it was a great day, and Judy is so knowledgeable and had so many answers for people. And by the way, just as a follow-up to that, we sat down with her afterwards and did a podcast with her. So last week's podcast, number 4, is with Judy, and we talk about a lot of the, a lot of the circumstances surrounding the payment suspension. So if you get a chance, folks, you might want to download that and check that one out, and please share it and subscribe when you do that, won't you? Okay. Before I introduce our guests, let me kind of set the stage here. We all know that home health in California and really across the country is being squeezed from every direction. You've got reimbursement pressures. You've got, you name it, staff shortages. Today, we're sitting down with 2 people who aren't just watching this shift. They've been building what comes next. They've helped agencies not just survive, but thrive in the middle of disruption. Many of you know Arnie. I think I met Arnie for the first time at probably a CASA conference years ago as we were wandering around the halls. Arnie Cisneros is president of Home Health Strategic Management with over 30 years of experience across post-acute care, ACOs, bundled payments, and CMS innovation models. Arnie's also been at the forefront of redefining how home health fits into the modern care continuum. And also with us today is Kimberly McCormick, who is the executive clinical director with over 2 decades in home health, including leadership as an agency administrator with deficiency-free surveys. What? Yes, deficiency-free surveys. And exceptional audit performance. So welcome to At the Table to both Arnie and Kimberly. And hi.
Hi, Mark.
Thanks.
Thanks for having us.
Yeah, not at all. So Sue, do you want to start us off, and we'll just kind of go back and forth and get the conversation started and enjoy each other at the table?
Yeah, absolutely. I mean, recently in the news, there's been so much focus on hospice, but we also represent home health. And what I wanted to start with was just a question around what's broken Arnie, and this could be either Arnie or Kimberly, but what's broken in the traditional home health model right now, and why can't agencies keep operating the way they have been in the past?
Well, that's a great question, Sue. I'm going to handle the first part of it, and then I'm going to turn it over to Kim to take it at an operational level. Home health is the newest of the Part A providers that Medicare manages, whether that's hospitals, LTACs, IRFs, skilled nursing facilities for subacute rehab, or home health. And over the last 35 years, Medicare has switched from volume to value for every one of those Part A providers. First hospitals, then nursing homes in 1995, and then us in 1999 with the IPS model. And those reforms continue. The Affordable Care Act moved us into a value platform, which says, how do we get people better with less volume that we did in the past? And they really started to move towards data management of the home health model, which was difficult for a subjective-based industry like home health up until that point to shift to that model. So one of the things that we talk about is we're getting patients in home health sicker and sooner. They're coming out of the hospitals and the nursing homes faster. Everybody wants home health. But as a result of that, home health is actually delivering the acute episode in many situations, rather than coming in after the acute episode is effectively completed at a hospital or a skilled nursing facility. So we have sicker patients, and we want to start to manage them via data. And then Medicare is focusing on the difference between care delivery and care outcomes. And now Medicare is paying for outcomes. And that's difficult for an industry that's really been valued according to delivering the care. So how do we take people who have been doing care delivery and then make sure they deliver the highest level of care delivery? And that's really difficult when the operational backdrop of home health has been based on a volume era that lasted for 30 years. So if an agency's nurses give 10 visits in the volume era, you'd think they would give less visits in the value era. And that's been difficult for home health to shift from volume to value, particularly in an operational matter that supports the outcomes they're looking for. So I'm going to turn it over to Kim, and she's going to talk about some of the things that we see when we walk into agencies that are looking to make these changes. And as a matter of fact, I know she's been on the phone all morning long with one of those agencies, so she can just speak from her heart there.
Thanks, Arnie. Thanks, Mark and Sue. I think to Arnie's point, one of the biggest things we talk about in our industry over the past 10 years and ongoing, the acuity level keeps getting higher of our patients. Yet we still manage operations like it's 1995. So still in a lot of areas, when we walk in, when I work with providers, for example, and I see those same things, nursing volumes of 1 week 9, no shifts have happened along those lines. And Medicare keeps pushing us down a path of using metrics, about managing what we're doing on a day to day. So we look at that and we say there is just such great opportunities for all providers out there to change the operational piece, use of metrics, objective data to manage the day to day, movement away from subjectivity to objectivity, and to really take a look at our patient population has changed. Why hasn't our operations changed and kept up with that? So back to Arnie's point, we talk a lot about volume. That has shifted over the last 26 years, but operations haven't kept up with that piece. So it's such a great opportunity to change. There is so much we can be doing as an industry to make those changes across the board. What else, Arnie, do you think about when I'm talking about that?
What I was thinking about when you were talking about that is the documentation for coverage model that every other provider in Medicare uses and that is new to home health. So let me describe that for the listener. When hospitals installed DRGs and went from 17 days to 3.7 days as an average length of stay, the hospitals didn't want to leave it up to the doctors and the nurses to manage such a decrease in utilization. So they created something called utilization review to read the doctors and the nurses' notes every night and manage the patient through the clinicians through objective documentation. So if a nurse writes that Mrs. Smith in 313 bed 2 moonwalked down the hall 50 yards today, Mrs. Smith is going home tomorrow. That's the same thing that happens in inpatient rehab
Yep.
facilities, in long-term acute care hospitals, and subacute rehab. In home health, we are very familiar with the model in which a therapist like myself says, I need more visits, Kim. And Kim says, how's the patient doing? And I say, they're doing good, but they need more visits. And she gives me more visits. And I finish the patient and the case gets audited and we get denied because it was not skilled. Meanwhile, I'm telling them, Kim, I need more visits to get the
Yep.
patient better. So in a documentation for coverage model, which we employ, Kim would say, okay, Arnie, I'll read your notes and see if the official documentation validates an extension that would qualify if we're audited by Medicare. And when she reads my notes and says, Arnie, there's nothing in your notes to justify an extension, I realize I'm actually writing to the case now, not just to myself.
Yeah.
And so that documentation for coverage allows me to demonstrate to both Kim in the notes and Medicare, if audited, how I'm doing skilled care. And that's just a minute example of the track that home health has been on for 30 to 40 years versus the track that non-home health Medicare Part A providers with the same regulations are on.
So let me ask Arnie this question, and then I have a follow-up for Kim. Arnie, you developed a search model, a service utilization review for care in the home. Break that down for us. What problem were you trying to solve?
Well, that's a great question, Mark. Thanks for asking me that. And I'm going to go back to my last answer. As Medicare swept the care continuum, first hospitals, then nursing homes, then home health, switching from volume to value with DRGs in the hospital and PPS for nursing homes and home health, Medicare created a utilization review program to manage nursing and therapy in a post-acute venue. And they created this for nursing homes, and it was called the MDS, or the minimal data set. And a staff member was identified, and it was called the MDS nurse. So we know that's what Medicare is doing. Medicare was managing utilization review via a nurse in a skilled nursing facility. And every time I did an assessment for this skilled nursing facility, I would have to go to meet with the MDS nurse and talk about Mr. Smith. How does Mr. Smith's strength look? Range of motion, transfers, balance, ability to walk safely. And she would take my answers, the MDS nurse, and she would put together a qualified plan of care for a skilled nursing facility patient based on the Medicare data. I also had the contract for the test agency for the state of Michigan for the new OASIS start of care document. And after I went into the nursing home one morning and did 2 admissions and answered the MDS nurse's questions, I went and did 2 admissions in home health for the OASIS test agency for the state of Michigan in 1996. And in the OASIS, I saw the same questions that the MDS nurse asked me regarding the nursing homes. So it occurred to me I could take the concomitant questions out of the OASIS and create a utilization review guide for nursing and therapy in a post-acute venue of home health based on Medicare philosophies and just manage our practice like that. And we did that. And then we had many agencies, a number of VNAs at the time, ask us to replace their rehab group because our patients got better so much faster and better on the Medicare scale. And that's just because we were using the Medicare scale.
Yeah.
So that's how search works. And search just complies with the Medicare guidance manual. I want to make this comment, Mark.
Sure.
There's nothing special about search. Anybody who said I could create my own search model by going to the regs and creating operational connections to those regs, and people occasionally have done that.
Yeah.
So even though it's proprietary to us, it's all publicly traded opportunities, and any agency can do that. And some agencies find themselves on that track a little bit, and they get better outcomes with lesser spending.
Sure.
And as a result, their margins go up.
Well, let me ask, and I think I called you Kim before, and I apologize. You prefer Kim or Kimberly?
Either one's fine, Mark.
Kim, like I've known you for years. I just Kimberly, let me ask you this. From a clinical leadership standpoint, how do you get nurses and clinicians to buy into a utilization-driven model without feeling like care is being restricted in some way?
Yep. That is a great question. People ask that all the time. We get them to buy in by using the rules. So what do I mean by that? Oftentimes the rules have been the same: homebound, skilled need, and under the care of a physician. If you understand the basics of that and then build from there, it becomes easy. So meaning, Mark, we don't get them to buy into anything other than let's follow the rules. Let's use objective data. Let's see where our patients are progressing to. Are the notes real time? Are they tied to a plan of care? So I'm gonna pause there for just a minute. We do Oasis on our patients. We are only accurate about 70% of the time on those scores.
Mhm.
There's a guidance manual. We don't use it. So, and the things that we do is we say, let's use that. Let's use that to figure out the accurate profile, because if it was our favorite aunt or uncle, the plan of care is being built off of something that's not accurate. When we start to teach about that and work with, these are licensed professionals in the field, and help them understand, when we get it accurate, we can create the accurate profile. We now can create a plan of care. Now we're going to drive to these outcomes. And by use of the objective metrics through scrubbers, through our reports, showing our clinical licensed professionals, look at what we're achieving now. Look at where we're going. So the volume area goes away. The concerns for them go away
Right.
when they see we can get better value and achieve these outcomes. And I think that is a really critical piece for our staff in the field. They're not tied to it. They think they're doing a great job, and they are.
Right.
But let's guide them, put the guardrails up, follow the regs, show them objectively, and that becomes the buy-in, if you will, for how they make that change.
So, continuing on here, one more thing. You've had deficiency-free surveys and
Yes.
extremely low audit error rates.
Yep.
Tell us what agencies are getting wrong when it comes to audit preparedness.
Yeah. I another great question. We speak about this all the time. We're retroactive as an industry. We look at things quarterly after the chart is closed, et cetera. And so, in my experience of running agencies, we did real time. We looked at notes real time. You can't manage patient care if you're not reading what's going on. And I know that is a big struggle for providers out there, because they're crisis management, trying to work through all the phone calls and the problems that have already occurred. So the way to achieve that is simply shifting the focus to real-time patient management, which, I had a long discussion with somebody this morning, a provider, about that this morning. How do we get patient notes 3 days, 5 days, 7 days after the fact? We don't stand a chance. So in the hospital, you wouldn't leave without your documentation done. In home care, that's a regular occurrence. She was busy, he was busy, etc. When we start to manage like other Part A providers in real time, and change to a real time model where we can read the charts and see what's happening with the patients, those pieces go away. Now, you're audit proof and denial proof in real time when you're doing it in real time. There's no concern about that after the fact.
Mhm.
I have a question for you as a follow up with that, Kimberly.
Sure.
If a provider was listening right now and they're
hmm
worried about ADRs, TPEs, and future
hmm
audits, what are the first three things they should fix immediately?
Timely documentation, start of cares that are same day, documentation in, quality review on regulatory and requirements from that first note, real time management. So, I think Sua, oftentimes there's a disconnect. I'm a great clinician. The documentation is something separate, and it's just not. So those are the things I'd recommend immediately: is real time documentation control and real time quality assurance review tied to the regulatory components of that, to make that shift.
Great. And then, Arnie, this question's for you. You've helped agencies reach 4.5 to 5-star ratings consistently. What's the biggest misconception about how star ratings are achieved?
Well, that's a great question. Thank you. What's interesting is star ratings were actually the primary and very insightful value um, scale for 10 to 15 years.
Mhm.
And all the way up until we went to PDGM, a star rating was meaningful. I was a
Mhm.
4.5 star. And then we entered PDGM and value-based purchasing. And that basically created another couple of levels above the current house with regards to how to achieve elite level outcomes. So one of the things that star ratings allows you to do is to perform and to be 15% above the national average for outcomes, and that gives you a 4.5 star rating. But that may not qualify for you for value-based purchasing today. So their star ratings is one of the legs of the table. There are now 3 other legs of the table in PDGM, which rewards rapid outcomes. And I think most of our industry is still not on that dynamic because PDGM was installed during the COVID era. So a lot of education did not actually hit home, and many people were working from home and working remote. So most people don't understand that switching from volume to value gives them better outcomes and patients that are ready to achieve those outcomes in a way that volume never did. And sometimes that's a difficult lesson for them to hear because they've done 20 years worth of value delivery. And, sometimes teaching value that pierces the volume noise is what we call it. For example, when we walk into an agency, agencies say it correctly, I've got 5 days to open the patient, 5 days to finish the plan of care. Those agencies are not aware that the average readmission day for home health is day 9. So if you're wasting the first 5 of 9 days, your readmission's already been decided then. And I know I've had to make this shift, and I think this is the struggle for our industry. I've had to tell myself, who did it for 35 years within 5 days start of care, it's important if we get in there within 24 hours.
Yeah.
People fall in the first 5 days and go back to the hospital. That's a difficult message for our industry to internalize and then extrapolate to a staff that spends 85% of their time not in the office. So that's what's difficult for our industry. If you're a nurse working in the hospital, they got you there for 40 hours. They're going to change your behavior pretty quickly. If they're talking to you for 40 minutes before you leave the door every day, that's a difficult culture change. But I do think it's available, and I think it's one thing that all agencies need to hear is there are many burdens that we carry from the volume era that go away and are eliminated when you switch to value.
And can I just add one other piece to that too? And I think that star rating, something I found myself, Sue was saying over the last year and a half easily, has been, never mind what your star rating is. Please talk to me about what your TPS score is. So as these metrics have changed and we have PPH and there are ways to get single digit rehospitalization, you can have a 4.5 star and be at 40% TPS. So, and that's difficult for agencies to think about. And so I always encourage people, star rating's only one piece of it. Look at your TPS score and see where you're at, because that really tells you about the care delivery and the outcomes.
Good point. Listen, let's do this. So we need to stop down real quick. We don't need to, but we want to. Before we go any further, I want to just take a moment to acknowledge and thank our presenting sponsor for today's podcast, Access. Plenty of leadership and support that they provide for California's home care community. When it comes to utilization and compliance and managing care in real time, you can't execute on any of this without the right infrastructure. And that's where Access really stands out, I think. More than 9,000 organizations using Access right now to care for over 5 million patients with certifications like High Trust and CHAP verified. You're not guessing. You know you can operate with confidence. So if you're serious about adapting to where home health is going, Access should be part of that conversation. And again, you can get more information at access.com. That's AXXESS.com. And again, we thank them for supporting CASA members. Arnie, we don't normally do this with our guests because we don't necessarily want them to market themselves, but give us just a brief 60 seconds on how you started your business and where you've been and where you're going and what you're doing.
Thank you for that, Mark. I was a physical therapist, and I started pre-DRG, so people stayed in the hospital for 17 days. Not many people used nursing homes. Not many people used home health. And I wrote a contract business with all of those providers. I had a hospital contract, an inpatient rehab facility contract, a nursing home contract, and a home health contract. So I was very familiar with the concept of treating a patient in a different care environment and having to be conscientious of what that care environment's rules were. I'm in a hospital. What do I do with this type of patient in a hospital? I'm in a nursing home. What's the difference in a nursing home? I'm in home health. So that connected us to the rules in a way that very few people were connected to.
Sure.
Also, at the time, I was worried about getting business, and I thought that by getting people better as fast as possible, that I would establish my bona fides as a quality clinician, and my private practice would thrive. And that's exactly what happened, because the rest of the industry was trying to treat people as long as they possibly could.
Right.
17 days for a hospital. And that put me on the value path. I can get you better this fast because I can. And as the Medicare reform swept volume to value, I'm on the value path I've been my whole career, and understand how to get people better faster than the traditional models. So when we switch from volume to value, one of the frustrating things for us is that Medicare effectively pays you to switch. If they switch you to PDGM and you start getting people better faster, you make more money. That's what they want.
Right.
But because we're not paying attention to that, the industry continues to take volume and spending all their margins to get it longer. And so those are things, let's get it right. We don't have to do these approaches. We get to do these new approaches. They're going to get patients better faster than we did in the past. And I would say to people in our industry, what I've said to myself for 40 years. If you want to get people better and do well financially, it happens fast, period. The longer you see the patient, the less they change and the less you get paid. So that's, you got to get in your car and drive it. It turns a standard shift automobile into a 5-gear. So that's difficult for people to do, especially when they don't know where they're going.
Yeah.
We know where we're going, but if you haven't done it 16 times, you don't know what the next step is.
So here, do this for us. Will you get out your crystal ball, your Arnie Cisneros crystal ball, and look ahead? Where do you think CMS is taking home health next, and what should providers be preparing for right now?
Well, Mark, I think we've spoken long enough to say this isn't my crystal ball. This is where they're going, because I stumbled into working with Medicare in the later last decade, and I did 6 years of bundle pilot programs with the Center for Medicare and Medicaid Innovation. And the first pilot program was a bundle for joint replacements, which meant the hospital owned the patient for the 30 days after discharge, and they managed everything. If the patients went to a nursing home, the hospital paid the nursing home. If the patients went to home health, patients went to home health. And in our bundle for joint replacements, we had a 72% decrease in skilled nursing facility volume. Where'd those patients go? They all went to home care.
Yeah.
And this was before COVID. This is before people didn't want to be in inpatient beds. So when we got done with that, we took the bundle concept, and with, again, Center for Medicare and Medicaid Innovation, we did a year-long bundle pilot program called post-acute PPS, in which every patient discharged from the Detroit Medical Center was managed via a bundle for the 30 days after discharge. And that post-acute PPS really changed the dynamic. You can think about how hospitals think. They wanted every patient opened on day one when they got home from the hospital. And if we had missed visits, we weren't going to use that provider anymore. And patients were achieving their goals in 17 to 24 days that we currently take 60 days in home health to do. So last month, Medicare announced that the CJR bundle that we did, which they ran for 3 years in 75 cities, is now being reinstalled next October 1st, 2027 nationally. So every joint replacement in America after next October, hip and knee replacements, will be bundled to the hospital, and the hospital will pay home health. So hospitals who don't have home health, if they're just seeing anybody in standard old way, the hospital will be paying for the errors. If a patient is readmitted, the hospital doesn't get paid.
Right.
So we're headed towards post-acute PPS, in which the hospital bundles all home health from hospital admissions for 30 days or more. And they will determine where the patient goes to home care, how much home care they get, whether they go to a skilled nursing facility or not. And the hospital will have the margins of being the convener of the entire episode. And having managed over 30 home health agencies through this model that were not hospital-based, even the best agencies, even the most efficient agencies, had to make significant changes to their programming to fit into this model. And then finally, the backside of that coin that is also introduced by Medicare recently is Medicare wants to know about our spending.
Right.
So it's not just care delivery, it's what did you spend? I guess I would have to say this. We're getting to the level, data-wise, in which Medicare says, if we pay you $6,000 for a patient, you spend $8,000 seeing them, that's not okay. If we pay you $6,000 for a patient, you spend $50 seeing them. That's not okay.
Right.
So it's a federal benefit program, and they want to make sure that they standardize these care. That's where it's going. And I would want to close with this. They want to give home health most of the patients, period. They want hospital length of stays decreased. They want inpatient decreased. And they're going to give it to home health, whether this home health industry is ready to accept it or not, because we're not available to learn the lessons, even though our margins go up while we learn them.
And hopefully we have enough staff to cover all those patients.
Well, we do.
Perhaps
We do.
that's another story. Well, we have time for just another question. You want to?
Yeah, sure. So for the last question, Arnie, we talked about different ways that the health agencies can thrive, but what separates top performing agencies from everyone else?
That's a great question, Sue. I'm going to give you a little a partial answer. I'm going to let Kim do it operationally as well. From my perspective, what separates it is attitude and enthusiasm. You know, if we're going to be a great agency, it's because we decided we were going to be a great agency, and we followed these differential questions that Medicare is changing in an ongoing manner, and that we had to show up for our staff. We're going to be great.
Yeah.
We're going to be proud of our care. Our patients are going to tell us how great we are, and that's not going to be necessarily easy every day. So if you want to be great, this is how we're going to do it. If you believe this is the same old home care and, oh, yeah, maybe this isn't the agency for you. But we're going and we're taking off now. And that is essential to move it forward, because, again, you're trying to manage people who are not in front of you for 40 hours. And you need to give them something to belong to. And, we always talk to other agencies, and they're going to go if somebody else pays them more. Quality clinicians do not go where they are paid more. They go where they belong to something that they feel is a quality care vehicle. So that's the way you keep patients. When we work with agencies, everybody says, all our people are going to leave. Nobody leaves, because people don't leave when they're challenged to give better care to their patients.
And I'll just add to that too, on top of what Arnie said. I think a big piece of that, Sua, is the courage to change. We talk about that a lot too. And yeah, you have to be enthusiastic. But again, we talk a lot about, let's make it a patient-centered model instead of a clinician-centered. And I am a clinician. I've been a clinician for a long time, in home care for over 30 years. I don't find anything wrong with putting the patient at the focus, but involving our staff in the understanding, in the rules of setting standardized operations to help them succeed in somewhat of a difficult environment. We're not in a brick and mortar building just being able to work. We're driving around trying to manage these things, but then to involve them in the outcomes and the understanding, so everyone's driving the car in the direction that we need to go. So I just wanted to add that on to Arnie's piece of, yes, enthusiasm is a huge component of it, the involvement of, the teaching of, but then the courage to change. I still hear a lot of people, Sua, saying, just grumbling about what the changes are. Arnie said it best. We don't have to do it. We get to do it. So with that enthusiasm, the biggest changes you can make.
Great. Well, thank you
Awesome.
guys both so much.
Yeah. Let's let me leave you with this. I think the pressure on home health isn't going away anytime soon. But just perhaps pressure creates clarity. And I think what we heard today is that the agencies that win aren't going to be the biggest ones. They'll be they'll be the ones that are most disciplined, and the ones that care the most, and the ones that want it, the ones that decide that they're going to win. That was great advice from both of you. Arnie, Kim, thank you for being here. Arnie, go Spartans. We found out we're both originally from Michigan, so go Michigan State Spartans. And thank you again to our sponsor, Access, for supporting conversations that move this industry forward. Website where people can find you, it's homehealthstrategicmanagement.com. Did I get that correct?
That's correct.
Homehealthstrategicmanagement.com, and you'll get all the information you need there. Thanks to all of you for listening and for the work you do every day to care for patients and families across California. If you'd like to drop us a note about a topic you'd like us to discuss or anything else you'd like to say to us, please be kind. You can email us at info@casa.org. That's info@casa.org. Thank you, Sue. Always good to see you.
Great, thank you.
And my name is Mark Wilson. This has been At the Table with CASA. And remember, this is your seat at the table, and we'll see you next time.